Welcome to a CDC update for clinicians on Zika virus disease, jointly provided by the Centers for Disease Control and Prevention and ID Care Live. My name is Dr. Joanne Kono, and I'm the Director of the Office of Science Quality here at the CDC. Activities on ID Care Live are interactive, allowing us to take your questions in real time throughout this presentation. We encourage you to answer questions at any time in the box below. Let's get started. The Zika outbreak is a rapidly evolving situation. Today, I'll share a brief update about the virus, the illness, the outbreak, and what CDC is doing to address these issues. First, an overview of the situation. Zika virus is a single-stranded RNA virus of the flavivirus genus. It's closely related to dengue, yellow fever, Japanese encephalitis, and West Nile viruses, and is transmitted to humans primarily by Aedes species mosquitoes. Two Aedes mosquitoes are able to transmit Zika, Aedes aegypti and Aedes albopictus. Aegypti is the more efficient vector. These mosquitoes also transmit dengue and chikungunya viruses. They lay their eggs in domestic water-holding containers, needing only small amounts of water, such as that in a bottle cap or a fallen leaf. They can live indoors and out and prefer to bite by day, though they also will at night. Humans are their favorite food source. This slide shows CDC's estimated ranges for both mosquitoes. You can see that they can be found in 1/3 to 1/2 of the geographic U.S. The Aegypti mosquito can be found across the southern U.S. and the albopictus mosquito across the southwest, as well as through the Midwest and Northeast. Other documented modes of Zika virus transmission include intrauterine and perinatal transmission, sexual transmission, and laboratory exposures. Additionally, blood transfusion and organ or tissue transplantation pose theoretical risks for transmission. We know that Zika virus can be spread by a man to his sex partners. In known cases of likely transmission, men had symptoms of Zika virus infection. But the virus can be spread before, during, and after men have symptoms. We also know that the virus can be present in semen longer than in blood. We don't know how long the virus is present in semen in men who have had Zika. We also don't know if infected men who never develop symptoms can have Zika virus in their semen or can transmit Zika virus through sex. And we don't know if women can transmit Zika virus to their sex partners. Given the potential risks of maternal Zika virus infection, pregnant women with male partners who have or are at risk for Zika virus infection should consider abstaining from sexual intercourse or use of condoms for the duration of pregnancy. The most common signs and symptoms of Zika virus disease include rash, fever, joint pain, and conjunctivitis. Other symptoms include muscle pain and headache. The incubation period of Zika virus infection is 3 to 14 days. The clinical disease is usually mild. Symptoms typically last several days to a week. In prior outbreaks, severe disease requiring hospitalization has been uncommon, and fatalities were rare. Recent reports have described Guillain-Barré syndrome in patients following suspected Zika virus infection. However, the relationship to the virus is not known. It's unclear how many people have had Guillain-Barré syndrome following a Zika infection. A recent report from Brazil during the current outbreak indicated that 6 patients aged 2 to 57 years had developed neurologic symptoms including Guillain-Barré and acute disseminated encephalomyelitis after laboratory-confirmed Zika virus infection. In a 2014 outbreak in French Polynesia, approximately 28,000 people were infected. Among these, there were 38 reported cases of Guillain-Barré syndrome. None were among children. Currently, in the U.S., there has been only 1 case of GBS in the states and 1 in the territories. Overall, GBS incidence from any cause appears to increase with increasing age. It may be challenging to distinguish Zika virus infections from those of dengue and chikungunya viruses. They are transmitted by the same mosquitoes with similar ecologies, and they can circulate in the same geographic area, but they rarely cause co-infections. Diseases due to all 3 viruses have similar clinical features. It is important to rule out dengue virus infection as proper clinical management can improve clinical outcome. Zika virus was first isolated from a monkey in Uganda in 1947. Before 2007, only sporadic human cases were reported from Africa and Southeast Asia. In 2007, the first outbreak of Zika virus disease was reported on Yap Island in the Federated States of Micronesia. Between 2013 and 2014, more than 28,000 suspected cases were reported from French Polynesia, with subsequent outbreak reports from other Pacific islands. This slide shows data on Zika virus incidence and attack rates based on a serosurvey conducted during the Yap Island outbreak of 2007. The infection rate was estimated to be 73%, and the symptomatic attack rate among those infected, 18%. All age groups were affected. However, adults were more likely to present for medical care. Among patients with Zika virus disease on Yap, there were no reports of severe disease, hospitalizations, or deaths. In May 2015, Brazil reported the first locally acquired cases in the Americas. Currently, outbreaks are occurring in 39 countries and territories in the Americas, including the Commonwealth of Puerto Rico, the U.S. Virgin Islands, and American Samoa. Further spread to other countries in the region is likely. Local vector-borne transmission of Zika virus has not been reported in the continental United States, but local transmission has been reported in U.S. territories. With the current outbreak in the Americas, the number of cases of Zika virus infection in U.S. travelers will likely increase. Imported cases may result in virus introduction to the continental United States, and local vector-borne transmission might occur in some areas of the U.S. This map shows cases of Zika virus in the United States and U.S. territories as of March 30th, 2016. The light blue color denotes where travel-associated cases are reported, and the dark blue shows locally acquired cases. In the states, there are 312 travel-associated cases. Of these, 27 were among pregnant women, 6 are sexually transmitted, and none are locally acquired. In the territories, there were 352 cases. Only 3 of these are travel-associated, and the rest, 349, are locally acquired. There are a number of diagnostic tests for Zika virus infection, including reverse transcriptase polymerase chain reaction to detect viral RNA in serum collected within 7 days of illness onset, and serology tests to detect IgM and confirmatory neutralizing antibodies in serum collected at least 4 days after illness onset. Immunohistochemical staining for viral antigens, or PCR, can be used on fixed tissues. Additional information regarding lab testing can be found on CDC's website. Laboratory testing for Zika virus infection and interpretation of the results can be complex. Zika virus serology can be positive due to antibodies against related flaviviruses such as dengue and yellow fever. Neutralizing antibody testing may discriminate between cross-reacting antibodies in primary flavivirus infections, but it can be difficult to distinguish the infecting virus in people previously infected with or vaccinated against a related flavivirus. Healthcare providers should work with local health departments to interpret test results. There are currently no commercially available diagnostic tests for Zika virus infection. Testing is being performed at CDC and a few state health departments. CDC is working to expand laboratory testing in the states. Healthcare providers are advised to contact their health department to facilitate diagnostic testing. There are no specific antiviral therapy for Zika virus disease. Treatment is supportive and entails rest and administration of fluids, analgesics, and antipyretics as indicated. As mentioned earlier, patients with suspected Zika virus infections should be evaluated and managed for possible dengue or chikungunya virus infections. Notably, aspirin and other nonsteroidal anti-inflammatory drugs should be avoided until dengue can be ruled out to reduce the risk of hemorrhage. As an arboviral disease, meaning that it is spread by an arthropod vector, Zika virus disease is a nationally notifiable disease. Healthcare providers are encouraged to report cases with laboratory evidence of Zika infection to their state, tribal, or local territorial health departments. Health departments are requested to report cases with laboratory evidence of Zika infection to CDC. Timely reporting can help health departments to assess and reduce the risk of local transmission and to mitigate further spread. Unfortunately, there are no vaccines or medications to prevent infection or disease. The primary prevention measure is to reduce mosquito exposure. CDC has issued travel notices advising pregnant women to consider postponing travel to areas with ongoing Zika virus outbreaks. People with Zika virus infection should be advised to prevent mosquito exposure during the first week of illness in order to prevent further mosquito-borne transmission to others. This is a Zika prevention kit, or ZPK. These kits are being distributed in Puerto Rico. They include health education materials and prevention tools such as mosquito repellents, bed nets, and condoms to help prevent Zika transmission to pregnant women. Now I'll discuss Zika virus in pregnant women. Currently, we have limited information about Zika virus infection during pregnancy. However, new evidence is emerging quickly. Existing data show no evidence of increased susceptibility to Zika virus in pregnant women, and there is no evidence that pregnant women have more severe disease compared with non-pregnant women. There is a possible link between Zika virus infection in pregnancy and adverse pregnancy and birth outcomes, including microcephaly. What is microcephaly? Well, first of all, it's a clinical finding, not a diagnosis. Infants with microcephaly have a head size that is smaller than infants of the same age and sex. For infants diagnosed with microcephaly, head size is a reliable assessment of brain volume. However, these measurements do not consistently predict long-term outcomes. Babies with microcephaly can have a range of other problems depending on how severe their microcephaly is. They may have seizures, vision or hearing problems, and intellectual and developmental disabilities. There are two mechanisms by which microcephaly in general can occur. One is by abnormal development, as is associated with a genetic cause. The other is by a disruption of normally forming brain tissue, usually by an infection or a vascular problem. This is suspected in Zika. Microcephaly is a difficult birth defect to monitor because inconsistent definitions and terms have been used. Typically, in the U.S., head circumference below the 3rd percentile on a standard growth chart identifies infants with microcephaly. However, standards can vary. The CDC guidelines for evaluation and testing of infants with possible congenital Zika virus infection provide a standard case definition for microcephaly. Surveillance systems in each country may also collect their data in different ways. Due to these challenges, most countries do not have an established baseline rate of microcephaly that can serve as a reference for the current outbreak. What do we know about Zika virus infection and microcephaly? Well, we know that laboratory tests from a small number of cases in Brazil suggest a link between Zika infection during pregnancy and microcephaly. The pattern of microcephaly associated with Zika virus infection is consistent with fetal brain disruption sequence based on photos and brain scans of a small number of affected infants in Brazil, and findings from a retrospective investigation of a Zika outbreak occurring in French Polynesia. This pattern has been seen in infants with other intrauterine infections, such as cytomegalovirus. CDC continues to evaluate all available evidence to determine if there is a causal relation between the reported cases of microcephaly in Brazil and Zika virus infection in pregnancy. We are also working to understand the full spectrum of phenotypes that might be related to Zika infection and the factors that may influence the risk of birth defects. This includes how the impact of timing of infection in pregnancy or the severity of illness may increase or decrease the risk of microcephaly and other poor pregnancy outcomes. In addition to microcephaly, a range of other problems have been detected among fetuses and infants infected with Zika virus before birth, including absent or poorly developed brain structure, defects of the eye, and impaired growth. Although Zika virus has been linked with birth defects and other problems in infants, there is much more to learn. Researchers are collecting data to better understand the impact of Zika virus infection on mothers and their children. Because there is neither a vaccine nor prophylactic medication available to prevent Zika virus infection, CDC recommends that pregnant women in any trimester consider postponing travel to areas where Zika virus transmission is ongoing. If a pregnant woman travels to an area with Zika virus transmission, she should talk to her healthcare provider and strictly follow steps to avoid mosquito bites during the trip. Healthcare providers should ask all pregnant women about their travel history. If a woman has had a history of travel to an area with ongoing Zika virus transmission during her pregnancy, her healthcare provider should evaluate her for symptoms of Zika virus infection, including fever, arthralgia, and conjunctivitis, and test for Zika virus infection according to the testing algorithm. Serologic testing for Zika virus can be offered to asymptomatic women with possible Zika virus exposure, those who travel to or reside in an area with ongoing Zika virus transmission. A negative IgM result could suggest that a recent infection did not occur and could obviate the need for serial ultrasounds. However, a negative serologic result cannot definitively rule out Zika virus infection. Information about the performance of serologic testing of asymptomatic persons is limited. CDC recommends a number of measures to prevent mosquito bites. Pregnant women at risk for Zika virus infection should use EPA-registered insect repellents, both during the day and at night. EPA-registered repellents, including DEET, are safe and effective for pregnant women when used in accordance with the product label. Pregnant women should wear long-sleeve shirts and pants to cover exposed skin, should stay and sleep in screened-in or air-conditioned rooms if possible, and should practice mosquito prevention strategies indoors and outdoors throughout the day and night. Pregnant women with male partners who have Zika virus infection or potential Zika virus exposure should use condoms the right way every time or abstain from sexual activity for the duration of pregnancy. In areas with ongoing Zika virus transmission, healthcare providers should evaluate pregnant women for symptoms of Zika virus infection and perform appropriate testing according to CDC's published guidelines. Local health officials should determine when to implement testing of asymptomatic pregnant women based on information about levels of Zika virus transmission and laboratory capacity. If testing is recommended, healthcare providers can offer serologic testing at the initiation of prenatal care and perform a follow-up test in the second trimester. And routine ultrasound screening is recommended for all pregnant women at 18 to 20 weeks of gestation. On February 5th, CDC updated its interim guidelines for U.S. healthcare providers caring for pregnant women during a Zika virus outbreak. The updated guidance provides updates on screening, testing, and management of pregnant women. These guidelines are available on the CDC website. Now I'd like to discuss acute Zika virus disease in infants and children. Available evidence regarding the spectrum of Zika virus disease in infants and children who are infected throughout mosquito bites indicates that most children are asymptomatic or have mild illness. This is similar to the findings seen in adults with Zika virus disease. In the Zika virus outbreak in Yap Island, Micronesia, in 2007, clinical illness was reported in people between the ages of 1 to 76 years. The most common signs and symptoms of illness reported were rash, either macular or papular, fever, arthralgia, and conjunctivitis. In that outbreak, children aged 0 to 19 years had lower attack rates of confirmed and probable Zika virus disease than did adults aged 20 to 59 years. Of the 8 recent travel-related cases of Zika virus disease among children in the U.S., all had rash and at least one other sign or symptom, including fever, arthralgia, and conjunctivitis. CDC recommends laboratory testing of infants with microcephaly or intracranial calcifications born to women who resided in an area with Zika transmission while pregnant, and for infants born to mothers with positive or inconclusive results for Zika virus infection. Infants with typical head size, normal ultrasounds, and a normal physical exam born to mothers who travel to or lived in areas with Zika do not require any special care beyond what is routinely provided to newborns. It is important to note that because information on the effects of congenital Zika virus infection is limited, healthcare providers should use clinical judgment in the assessment of newborns with abnormalities other than microcephaly or intracranial calcifications who were born to mothers who traveled to or resided in an area with active Zika virus transmission during pregnancy. For these infants, healthcare providers should consider testing the mother before testing the infant. CDC's guidelines will continue to be updated as additional information becomes available. To assist clinicians caring for infants and children with possible Zika virus infection, CDC published updated interim guidelines on February 19th. These guidelines are available on the CDC website. At CDC, we are working with public health partners and state and territorial health departments to inform healthcare providers and the public about Zika virus infection and to provide updated information as it becomes available. This includes detecting and reporting the spread of Zika virus, guiding new public health interventions to prevent infection, and developing and disseminating guidelines to inform the evaluation, testing, and clinical management of people with suspected Zika virus disease. This is a photo of CDC's Emergency Operations Center, which coordinates our public health emergency response to Zika. CDC has over 100 staff members responding to the outbreak, working in Latin American countries, the continental U.S., and the U.S. territories. Since very little is known about the risks of Zika virus infection during pregnancy, an increased understanding of the impact of Zika on pregnant women and their infants is needed. To learn more about this, CDC is collaborating with state, tribal, local, and territorial health departments to collect information about women infected with Zika during pregnancy and their infants. The information collected will direct public health efforts intended to mitigate the impact of Zika and guide recommendations for the monitoring and treatment of women affected by Zika during pregnancy. In collaboration with state and territorial health departments, CDC has established 2 surveillance systems for pregnant women with Zika virus infection. The U.S. Zika Pregnancy Registry aims to include all pregnant women with probable or confirmed Zika virus infection who are residents of the United States and the District of Columbia. The Zika Active Pregnancy Surveillance System, or ZAPS, will collect data from medical records of pregnant women and their infants in Puerto Rico. Data collected from both of these surveillance systems will be used to gain more information about the timing, risk, and spectrum of outcomes associated with Zika virus infection during pregnancy, to direct public health action and guide testing, evaluation, and treatment. CDC maintains a 24/7 Zika pregnancy hotline for healthcare providers of pregnant patients with possible Zika virus infection. Through this service, we are available to provide guidance for providers caring for pregnant women, infants, and children with possible Zika virus infection via telephone or email consultation. You can reach this service by calling the CDC Emergencies Operations Center at 770-488-7100 and asking for the CDC Zika Pregnancy Hotline, or by emailing zikamch@cdc.gov. So to summarize, Zika virus continues to circulate and cause locally transmitted disease in the Americas. Healthcare providers should consider the possibility of Zika virus infection in travelers with acute fever, rash, arthralgia, or conjunctivitis within 2 weeks of return from an area where Zika virus transmission is ongoing, or in those who reside in an area with reported Zika virus transmission. Reports from Brazil indicate a substantial increase in the rate of congenital microcephaly, and research is underway to help characterize this relationship. Pregnant women in any trimester should consider postponing travel to areas of Zika virus transmission. CDC has created a special suite of online resources, including Q's and A's for pregnant women and healthcare providers, and communication products in both English and Spanish. There are many online resources available to learn more about Zika virus infection. Here are a few. For travelers, CDC regularly posts advisories about Zika virus on its Travelers Health website. Finally, I'd like to thank CDC's many collaborators, including International Ministries of Health, the World Health Organization, the Pan American Health Organization, state, territorial, and local health departments, and professional organizations such as the American Academy of Pediatrics, the American Congress of Obstetricians and Gynecologists, and the Society for Maternal Fetal Medicine, and many, many others. Now I'd like to address your questions that have come in throughout the program. Okay, the first question we have, if a woman is visiting a Zika virus endemic area, how long should she wait to become pregnant after returning from the area? This is a great question. So, of course, a woman who is interested in becoming pregnant should discuss this with her healthcare provider. It's advised, based on the incubation period of Zika, that a woman should wait 8 weeks or so after returning before coming pregnant. It's also been asked, how long should a man wait after returning from a Zika infected area? And that also is an 8-week period in general, but we recommend that up to 6 months, because we don't know how long Zika virus can exist in semen. The longest that we have information about to date is 64 days after illness, and so we do like to be cautious. So 6 months for men, 8 weeks for women, and use of condoms if there is a chance of infection. Are there any recommendations for postnatal moms who are breastfeeding? Should they continue to use condoms if their male partner just changed. Should they continue to use condoms if their male partner is or has had exposure to Zika virus? Well, I think I answered the condom and abstinence question. But as far as breastfeeding, there is no information that breastfeeding poses a risk to infants. And we're advising the benefits of breastfeeding outweigh the risks, and so we advise breastfeeding women to proceed. One question is, are the calcifications able to be seen in utero? So these are the intracranial calcifications in a fetus. And yes, they are. This becomes more evident later in the pregnancy. As you may know, the routine ultrasound screening in pregnant women occurs about 18 to 20 weeks in any pregnancy. And so after that, at that time and afterwards are when we're most likely to see intracranial calcifications. Here's another question. Is testing of semen of men with possible exposure to Zika virus recommended? At this time, we're not recommending testing of semen. We don't have enough information to interpret the tests and aren't doing that on a widescreen basis. Is there any known association between maternal Zika virus infection and other adverse pregnancy outcomes? Well, I named a few. The ones that we are most familiar with are the brain defects. Also, there can be impairment of vision and hearing. And there are also some malformations that may occur to the extremities. We see an increased incidence of clubfoot and other such extremity deformations. Let's see, scrolling a little bit further. Other than age, is there any way to predict those who may develop GBS? In general, across all causes of GPS, I think that's a difficult prediction to make. So no, we don't have good information about who may develop GBS, either in GBS in general or in this association with Zika virus disease. As I mentioned, infection is a common insult that may lead to Guillain-Barré syndrome. Is there a value to know the IG status for Zika to show past exposure or recovery? At this point, I would say our information is very limited, and we don't have enough information to advise on that just yet. Another question, are future pregnancies at risk with prenatal exposure? We are advising at this point that no, we do not have any reason to believe that future pregnancies are at risk because of a prenatal exposure for a recent pregnancy. If only 20% of infected adults have clinical symptoms, can asymptomatic adults transmit the virus to sex partners or the fetus? Asymptomatic adults transmit the virus to. When we're talking about transmission between adults, we can only talk about the man at this point. We do not know if women are able to transmit the virus. And whether or not asymptomatic men can transmit, it's possible, and that's why we're recommending condom use for up to 6 months after returning from travel. Is there lifelong immunity after a recovered Zika infection? That too is not clear. I believe that we think there is, but I would have to say that we need to learn more about that situation. Is the Zika virus rash distinctive in children? The rash is not. As I've mentioned, it can be macular or papular in either adults or children, and is an erythematous rash. How long after being infected could a woman become pregnant without risk to the fetus? After being infected is a different situation than being exposed. However, after we're advising that women postpone pregnancy 8 weeks out of travel, so that would apply also to being infected. That viremia itself is a very short period of time, usually a week or so, but we are recommending 8 weeks to be more cautious about that. What are the predictions for locally acquired infection rates for this summer with expanding territory of these species of mosquitoes? That's a great question. We do anticipate that we will see some locally acquired spread in the continental U.S. For this reason, we're advising that people use, in areas where active transmission is ongoing, we're advising that people use, when returning, use insect repellent for a week after disease and for 3 weeks after returning. We're trying to limit the transmission of the virus from ill people or people who are carrying the virus into the U.S. domestic mosquito population. Have there been reports of co-infections with dengue and or chikungunya on top of the Zika infection? I'm not sure about on top of Zika, but we know that dengue and chikungunya can occur together, can be co-infections. We think this happens rarely, and we think it's likely to happen rarely with Zika infection. So I would say possible, but we don't have a lot to report on that just yet. Sorry, I'm doing some scrolling through as new questions pop in. Is it possible for a patient with a history of chikungunya virus to contract Zika virus and develop symptoms? Yes, absolutely, and hence our concern. As I mentioned, it may be a little more complicated in interpreting test results when someone has previously been infected or been vaccinated against one of the other flaviviruses. So that's why, because our tests are new and because this can be a complex situation to navigate the interpretation of these tests, that's why we advise healthcare providers to consult with health departments to interpret the results. How long does IgM remain positive or elevated? That can go out as long as 12 weeks and perhaps beyond. What are the expected, as new questions come in, they jump around on the screen. What are the expectations time-wise for the development of a vaccine? I don't have good information about that. I'm sure that those of you who follow the media have heard a lot of different predictions on that one, but I'll have to defer a firm answer on that. Are there any drug therapies, such as ivermectin, in clinical trials for Zika? Not that I'm aware of. As I mentioned, we don't currently have a drug therapy for Zika or a vaccine. How common is fever with Zika virus disease? It is true that our recent reports and historic reports about Zika virus suggest that not everyone has fever, and so it is variable. I mentioned in the pediatric cases that we've seen thus far that rash has been a consistent finding, but we're working to learn more about the natural history and presentation of the disease. Someone is wondering if we may miss cases if clinicians rely on the presence or history of fever prior to testing. It's true that it is quite likely that we're missing cases, not only because the signs and symptoms may be inconsistent with what people anticipate, but also because some people are infected and asymptomatic. So as we learn more about the illness and revise our case definition for the illness, I hope we'll be able to zero in more closely on this. But as many other illnesses, the signs and symptoms can be inconsistent. But fever, rash, and conjunctivitis is more prominent in Zika virus as compared to chikungunya or dengue. Does the yellow fever vaccine offer any cross protection against Zika virus infection? Not that we're aware of. Has it been proved that there is transmission by Aedes albopictus in addition to Aedes aegypti mosquitoes? Because both of these mosquitoes are able to transmit other flaviviruses, it's believed that albopictus would possibly do that as well. I don't know if it has been proven. But so much is similar about the two mosquitoes and the other viruses that they can transmit. If Zika virus IgM decreases after 12 weeks, what are the recommendations for pregnant women exposed more than 3 months ago if IgM is negative? If a pregnant woman was exposed more than 3 months ago, and I presume that the person asking the question means that those 3 months are during the course of the pregnancy, the woman would receive her standard ultrasound, and evaluation would go on from there. If testing is inconclusive, retesting can be done, and of course a evaluation of the child after birth is important too. What mosquito control measures are being planned or are in place? This is a great question. So we talked a lot about what people can do personally to address or to prevent mosquito bites. And as far as mosquito control, a lot of the effort there relies very closely on water sources around the home. These mosquitoes stay very close to humans. They prefer to feed on humans. They can live very well inside and lay eggs in very tiny water. And their eggs can survive dry conditions as well. So it's very challenging to address this. Some of the mosquito control programs that are possible are treating individual homes. In Puerto Rico, there's an effort to treat the homes of pregnant women. And then wider mosquito control measures are also being considered. But because these mosquitoes live so closely around the home environment, individual citizens can have a lot of impact and control about what's happening in their immediate environment. What is being done about blood transfusion, and how long before being allowed to donate blood? This is a great question. In Puerto Rico, the FDA had issued some advisories about how to manage blood transfusion because transmission is happening locally. And so different blood products are being treated, and blood products are being supplied to the area. As far as I know, I don't know about limitations of how long before someone is allowed to donate blood, but I would think it would be very similar to the recommendations that we're making about pregnancy prevention and precautions for sexual transmission. Okay. Well, I think that the question period has slowed here. So I'd like to thank you, the audience, for great questions. Please visit idcarelive.com to view other infectious disease programs on demand. My name is Dr. Joanne Kono. Thank you for joining us.